So for the overview, we have the etiology. We're going to discuss the epidemiology, pathology, pathogenesis, the clinical manifestations, diagnosis, complications, and treatment and prevention. So mumps is an acute self-limited infection characterized by fever, bilateral or unilateral parotid swelling, and tenderness, and the frequent occurrence of meningoencephalitis and architis. Although it is infrequent in countries with extensive vaccination programs, mumps remains endemic in the rest of the world, warranting continued vaccine protection. For the etiology, mumps virus comes from the family Paramyxoviridae under the genus Rubiola virus. This is a single-stranded pleomorphic RNA virus encapsulated in a lipoprotein envelope possessing seven proteins. Surface glycoproteins present include the hemagglutinin neuraminidase or the HN glycoprotein, which would mediate absorption of the virus to host cells, and fusion glycoprotein, which would facilitate the penetration of the virus into cells. So both of these proteins would stimulate production of protective antibodies. Mumps virus exists as a single serotype with up to 12 known genotypes, and humans are the only natural host. For the next is the epidemiology. So in the pre-vaccine era, mumps occurred primarily in young children between the ages of 5 and 9-year old, and in epidemics about every 4 years. Transmission is via respiratory droplets. So the virus would appear in the saliva from up to 7 days before to as long as 7 days after onset of parotid swelling. The period of maximum infectiousness is 1 to 2 days before until 5 days after onset. So the USCDC has recommended an isolation period of 5 days after onset of parotitis for patients with mumps in both community and healthcare settings. For the pathology and pathogenesis, mumps virus would target the salivary glands, CNS, pancreas, testes, and to a lesser extent, thyroid, ovaries, heart, kidneys, liver, and joint synovia. So initial viral replication occurs in the epithelium of the upper respiratory tract. Infection would then spread and spread to the adjacent lymph nodes by the lymphatic drainage, and viremia would now ensue, spreading the virus to targeted tissues. So this would now cause necrosis of infected cells and is associated with a lymphocytic inflammatory infiltrate. The salivary gland ducts are lined with necrotic epithelium, and the interstitium is infiltrated with lymphocytes. Swelling of the tissue within the testes may result in focal ischemic infarcts, and the CSF frequently contains a mononuclear pleocytosis, even in individuals without clinical sense of meningitis. For the clinical manifestation, so the incubation period would range from 12 to 25 days, but is usually 16 to 18 days, with a prodrome lasting 1 to 2 days, which consists of fever, headache, vomiting, and achiness. Clinical presentation ranging from asymptomatic to typical illness associated with parotitis with or without complications involving several body systems. So the parotitis would peak in approximately 3 days and then gradually subside over 7 days. As we can see here in the picture, the typical patient would present with parotitis and may be unilateral initially but becomes bilateral in approximately 70% of cases. The parotid gland would become tender and parotitis may be preceded or accompanied by ear pain on the ipsilateral side. As the swelling progresses, the angle of the jaw is now obscured and the earlobe may be lifted upward and outward, and the opening of the Stenson duct may be red and edematous. For other clinical manifestations, so fever and the other systemic symptoms may resolve in 3 to 5 days. Morbilliform rash is rarely seen. Submandibular salivary gland enlargement without parotid swelling. Edema over the sternum as a result of lymphatic obstruction. Symptoms in immunized individuals are the same, but tend to be less severe and parotitis may be absent. For the diagnosis, when mumps was highly prevalent, the diagnosis could be made on the basis of history of exposure to mumps infection, appropriate incubation period, and development of typical clinical findings. Elevated serum amylase value would serve as confirmation of the presence of parotitis. Could be made with leukopenia with a relative lymphocytosis. So in highly immunized populations, patients with parotitis lasting longer than 2 days and of unknown cause, a specific diagnosis of mumps should be confirmed or ruled out by virologic or serologic means. There is a significant increase in serum mumps IgG antibody between the acute and convalescent specimens. And in enzyme immunoassay for mumps, IgM, is used to identify recent infection. So all serologic tests are difficult to interpret in immunized individuals, and negative test results do not rule out mumps infection. For the differential diagnosis, so viruses, the examples of viruses that can cause parotitis would include, next slide please. Santap, mapa next slide please. Thank you. So, for the differential diagnosis, the viruses that cause parotitis would include parainfluenza 1, parainfluenza 3, influenza A virus, cytomegalovirus, Epstein-Barr, lymphocytic choriomeningitis virus, and HIV. Purulent parotitis is caused by Staphylococcus aureus and is usually unilateral and extremely tender and is associated with elevation of WBC and may involve purulent drainage from the Stensen duct. So for complications, the common complications would include meningitis with or without encephalitis. And for the gonadal involvement, this would include orchitis and oophoritis. Maternal infection with mumps during pregnancy can lead to increased fetal wastage. So there is no fetal malformations that have been associated with intrauterine mumps infection. However, perinatal mumps disease has been reported in infants born to mothers who acquired mumps late in gestation. Next slide, please. Now, for the other complications, this will So this includes meningitis and meningoencephalitis. So mumps virus is neurotropic and is thought to enter the CNS via the choroid plexus and then infect the choroidal epithelium and ependymal cells, both of which can be found in CSF along with mononuclear leukocytes. So symptomatic CNS involvement would occur in 10 to 30% of patients, and CSF pleocytosis have been found in 40 to 60% of patients with mumps parotitis. The meningoencephalitis may also occur before, along with, or following the parotitis. So it most commonly manifests 5 days after the parotitis, and clinical findings would vary with age. For infants and young children, they would have fever, malaise, and lethargy, whereas older children, adolescents, and adults would complain of headache and demonstrate meningeal signs. Less common complications of mumps include next is orchitis and oophoritis. So in adolescent and adult males, orchitis is only second to parotitis as a common finding in mumps. So involvement in prepubescent boys is extremely rare. After puberty, orchitis occurs in 30 to 40% of males. It begins within days following onset of parotitis in most cases, and is associated with moderate to high fever, chills, and exquisite pain and swelling of the testes. In 30% or less of cases, the orchitis is bilateral. Next is atrophy of the testes. So this may occur, but sterility is rare even with bilateral involvement. Oophorytis is uncommon and is typical to females, but may cause severe pain and may be confused with appendicitis when located on the right side. Next is pancreatitis. So this may occur in mumps with or without parotid involvement. So severe disease is rare, but fever, epigastric pain, and vomiting are suggestive. Next is cardiac involvement. So myocarditis is common in mumps, and molecular studies have identified mumps virus in heart tissues taken from patients with endocardial fibrinolysis. Another complication is arthritis. So arthralgia, monoarthritis, and migratory polyarthritis have been reported in mumps. So arthritis is seen with or without parotitis and usually occurs within 3 weeks of parotid swelling. So the arthritis is generally mild, self-limited. Thyroiditis is rare following mumps and it has not been reported and may occur weeks after the acute infection. Most cases would resolve, but some become relapsing and result in hypothyroidism. For the next slide is the treatment. Less common CNS complications include transverse myelitis, acute disseminated encephalomyelitis, aqueductal stenosis, facial palsy, and sensory neural hearing loss. For the treatment and prognosis, so management should be aimed at reducing the pain associated with meningitis or orchitis and maintaining adequate hydration. Antipyretics may be given for fever. However, there's no specific therapeutics available for mumps. For the prognosis, the outcome of mumps is nearly always excellent, even when the disease is complicated by encephalitis, although fatal cases from CNS involvement or myocarditis have been reported. So there are no deaths that have occurred in the recent outbreaks in the US. For the prevention, the primary mode of prevention is immunization with a live mumps vaccine. So according to Nelson's, the MMR2 dose vaccine schedule is first dose is given at 18 months of age, second dose being given 4 to 6 years of age. So if it's not given 4 to 6 years, the second dose should be given before children enter puberty. So in those traveling, two doses are recommended in individuals older than 12 months, administered at least 28 days apart. And during outbreaks, a third MMR dose administered to the at-risk population is given. So as a live vaccine, MMR should not be administered to pregnant women, patients who are severely immunodeficient, and immunosuppressed individuals. For HIV-infected patients who are not severely immunocompromised, they may receive the vaccine because the risk for severe infection with mumps outweighs the risk for serious reaction to the vaccine. So individuals with anaphylactic reactions to egg or neomycin may be at risk for immediate type hypersensitivity reactions to the vaccine. Next slide. So, acceptable presumptive evidence of immunity to mumps consists of one of the following: documentation of adequate vaccination at ages 12 months or older, laboratory evidence of immunity, birth before 1957, and documentation of physician diagnosed mumps. And evidence of immunity through documentation of adequate vaccination is defined as one dose of a live mumps virus vaccine for preschool age children and adults not at high risk, and two doses for school age children and adults at high risk. That's all